we may be prescribing oxygen to ILD patients with little real-world benefit. And in the ICU, a therapy many of us still reach for in severe vasculitis, plasma exchange, may not actually improve survival. In the next few minutes, we'll break down a randomized trial on ambulatory oxygen in pulmonary fibrosis, a real-world ICU study on plasma exchange in diffuse alveolar hemorrhage, and finish with a practical physiology-based review on ventilating obese patients. These are 3 studies with direct implications for how we practice pulmonary and critical care today. Welcome to This Week in Pulmonary and Critical Care Medicine, where we focus on what actually changes, or should change, how you practice. Let's start with oxygen therapy in ILD. Ambulatory oxygen is widely prescribed in patients with fibrotic interstitial lung disease who desaturate on exertion. The assumption is intuitive: correct hypoxemia, improve activity, improve quality of life. But that assumption has never been strongly supported by real-world data. Published in the Lancet Respiratory Medicine in February 2026, the PFOX trial directly tested this question in a randomized, sham-controlled design. This was a multicenter trial including 116 patients with fibrotic ILD and isolated exertional hypoxemia, defined as SpO2 equal to or less than 88% during a 6-minute walk test. Patients were randomized to ambulatory oxygen via portable concentrator or sham air, with identical devices to maintain blinding. The primary endpoint was change in physical activity, measured as mean daily steps at 3 months. Now here's where things get interesting. Patients receiving oxygen had a change of minus 271 steps per day, compared to 64 steps per day in the sham group. The between-group difference was minus 334 steps per day, with a 95% confidence interval of minus 803 to 134, not statistically significant. So clinically, oxygen did not improve activity, and if anything, trended toward less activity. And importantly, the confidence interval excludes any meaningful positive effect on physical activity. There were also no differences in adverse events, symptoms, or functional outcomes. So what does this mean? This is the first properly powered, real-world RCT assessing ambulatory oxygen in daily life, not in lab conditions. And it directly challenges the assumption that correcting exertional desaturation improves meaningful outcomes. The likely explanation is practical rather than physiological. Portable oxygen devices are heavy, cumbersome, and socially limiting, and patients may actually move less because of the burden. This aligns with what we see clinically. Patients prescribed oxygen often don't use it consistently. Now, before you overcorrect, this study does not apply to resting hypoxemia or advanced disease requiring long-term oxygen therapy. It specifically addresses isolated exertional desaturation. The sample size is modest, n equals 116, and adherence to device use varies. But the direction of effect and confidence intervals make a clinically meaningful benefit unlikely. This is not just no benefit. It suggests we may be overprescribing a burdensome therapy without real-world gains. In practice, this means that for ILD patients with isolated exertional hypoxemia, ambulatory oxygen should not be routinely prescribed without a clear patient-centered discussion about uncertain benefit and real burden. Diffuse alveolar hemorrhage in ANCA-associated vasculitis is one of the most stressful ICU scenarios we face, and for years, plasma exchange has been used based on pathophysiological rationale, removing antibodies, inflammatory mediators, and potentially improving outcomes. But evidence has always been shaky. Published in the American Journal of Respiratory and Critical Care Medicine, this study attempted to answer the question using a different approach, a target trial emulation. A quick note on what they mean by a target trial. This isn't a real randomized trial. It's the ideal study you wish you could run. So the investigators first define that perfect trial: who gets treated, when treatment starts, and what outcomes matter, and then try to recreate it using real-world data. They use methods to mimic randomization and reduce bias, so it's stronger than a typical retrospective study, but still not as definitive as a true randomized trial. The cohort included 184 ICU patients with severe DAH across 42 centers. 78% received plasma exchange, 54% required mechanical ventilation. The median severity, or SAPS-2, was 42. The primary outcome was 30-day mortality. Survival with PLEX was 85%, and survival without PLEX was 88%, with a hazard ratio of 1.23 and a confidence interval that crosses 1. So no statistically significant difference. And importantly, no signal toward benefit across secondary outcomes, including ICU length of stay, ventilation duration, longer-term mortality. This aligns with PEXI-VAS, which also showed no mortality benefit, even though DAH subgroup data were limited. So now we have RCT data in PEXI-VAS, observational target trial emulation, both with consistent findings, no benefit. So why does PLEX fail? The biology makes sense, but the disease is more complex. Damage is already established by the time patients present. Removing antibodies may be too late, and immunosuppression likely drives outcomes more than extracorporeal removal. This is still observational, even with advanced methods. Residual confounding remains possible. The study may also be underpowered to detect smaller effects. Nonetheless, there is now converging evidence that PLEX does not meaningfully improve outcomes in DAH due to ANCA-associated vasculitis. In practice, this means that plasma exchange should not be used routinely in ANCA-associated DAH, and its use should be highly selective rather than reflexive. Let's shift gears from trials to physiology. Published in Intensive Care Medicine in 2026, this review tackles something we deal with all the time in the ICU, but often get wrong: how to ventilate patients with obesity. The easiest way to think about this is that obesity is not just a bigger patient. It's a different respiratory system altogether. What actually changes isn't primarily the lung, it's the chest wall. Pleural pressure is higher, the diaphragm is pushed upward, and functional residual capacity drops significantly. In fact, FRC decreases by about 5 to 15% for every 5 kilograms per square meter increase in BMI. So many of these patients are breathing right at or even below their closing capacity. Airways begin to close during normal tidal breathing, atelectasis develops early, and that's why they desaturate so quickly, even with relatively minor insults. Now here's where most clinicians go wrong. You look at the ventilator and see a plateau pressure in the low 30s or a driving pressure that feels uncomfortably high. The instinct is to think, I'm over-distending the lung, I need to back off. But in obesity, that interpretation can be misleading. Those elevated pressures often reflect a stiff chest wall and high pleural pressure, not excessive lung stretch. So airway pressure doesn't necessarily equal lung stress in this population. And if you don't recognize that, you end up making the wrong adjustment. The common reaction is to lower tidal volume or reduce PEEP in an attempt to protect the lung. But what actually happens is the opposite of what you intend. You promote alveolar collapse, worsen atelectasis, and oxygenation deteriorates. You've optimized the numbers, but not the physiology. So the shift in thinking is critical here. Instead of focusing on airway pressures alone, you need to think in terms of transpulmonary pressure. What pressure is actually distending the lung? Practically, that changes how you approach ventilation. Tidal volume still needs to be based on predicted body weight. This doesn't change. Lung size doesn't increase with obesity, so using actual body weight will lead to excessive volumes and potential injury. But PEEP is where things really differ. These patients often need higher PEEP than we're used to using because you're trying to counterbalance elevated pleural pressure and keep alveoli open. What feels like high PEEP may actually be physiologically appropriate. Another common mistake is how we respond to hypoxemia. If you simply increase FiO2 without addressing the underlying atelectasis, you may transiently improve saturation, but you worsen absorption atelectasis and never fix the real problem, which is alveolar collapse. So in obesity, hypoxemia is often a recruitment problem, not just an oxygen delivery problem. And then there's the practical side. These patients desaturate rapidly during apnea, are more difficult to intubate, and have a higher risk of extubation failure. That means your margin for error is smaller. Positive pressure pre-oxygenation becomes essential, and there's a strong case for using non-invasive ventilation after extubation in selected patients. The deeper takeaway here is that obesity fundamentally shifts the problem from ventilating the lung to managing the interaction between the lung and the chest wall. If you treat these patients like standard ICU patients, you'll underpeep, misinterpret pressures, and likely worsen outcomes. There are limitations. Most of the evidence here is physiological or extrapolated, and we still lack robust obesity-specific trials. But the physiology is consistent, and it explains what we see at the bedside every day. In practice, this means that in obese ICU patients, you should be cautious about interpreting airway pressures in isolation, prioritize adequate PEEP to prevent collapse, and approach hypoxemia as a problem of atelectasis rather than simply low oxygen. 3 studies, 3 different messages. A therapy we routinely prescribe in ILD may not improve real-world outcomes. A long-debated ICU intervention continues to show no survival benefit. In a common ICU population, patients with obesity requires a completely different physiological approach to ventilation. If you're practicing pulmonary or critical care today, these are not abstract findings. They directly affect what you do tomorrow. Until next week, this is Dr. Aladdin Sagar, signing off.